Good morning. Joanne, can you hear me?
Yeah, yeah, we can hear you.
Okay, good morning. Sorry, the network is not very good. So let's pray. Father, we thank you for today. Bless your holy name. Thank you for the gift of life. We thank you that we are able to move, to do the things that you have asked of us. We are able to attend to our duties. We're able to see the faces of the ones that we love. It is for your goodness, your mercy, your grace. We bless your holy name. We ask that, Father, as we are about to study, to share knowledge, that you come be with us, that you assist us, that you make everything that we do here be successful. In the name of Jesus Christ, we pray. Amen. Today, today's topic is uh, polycystic ovary syndrome or polycystic ovarian syndrome. That is what we'll be discussing. This is the outline. We'll start with a short introduction. We'll go to the types, the anatomy of the ovaries, the cause of PCOS, the physiology of the ovarian cycle, and then what goes wrong to cause the PCOS, the signs and symptoms of PCOS, the tests you're supposed to do, how to make your diagnosis, the complications of having polycystic ovarian syndrome, the management, and then the differentials. Okay, so polycystic ovarian syndrome. Polycystic ovarian syndrome is a common condition that affects women of reproductive age. It usually starts during adolescence, and then the symptoms may do that fluctuate over time. It's the cause of PCOS is not known, but we know that there's excess androgen, the male hormones, and then it causes citizen in women. We'll come to that. PCOS is a chronic condition. It cannot be cured, and then even though it cannot be cured, some of the symptoms can be improved through medications, treatments, lifestyle changes, and fertility treatments. So this we'll talk about in the pathophysiology, but it is primarily defined by excess androgens in your body. It was originally called Stein-Leventhal syndrome, and then it was changed to PCOS. That was because two people began to describe this syndrome. One called Stein, one called Leventhal. So it was initially named after them, Stein-Leventhal, and then it was changed to PCOS. Okay. So first of all, it is called a syndrome, not a disease, because a syndrome is a group of signs and symptoms that occur in a particular condition, but without a known cause. So usually most diseases have a known cause. Okay, but when we talk about syndromes, we don't usually know the cause of the problem, but we know that some specific uh, symptoms and signs occur in that condition. And then so we group those signs and symptoms and then we call them a syndrome. That's why it is a disease, it's a syndrome, not a disease. Okay. And then you can tell from the name, poly. Poly means more than one. And then a cyst is a fluid filled sac. Okay. So polycystic, many fluid filled sacs. And then the fluid filled sacs are seen on the ovary. That is why it is called polycystic ovarian syndrome. So there are types of PCOS. They are described as type A, B, C, and D. This is not very important, so we'll not go into it. But in case you want to classify your type of PCOS, the type A has delayed ovulation, high androgens, and polycystic ovaries. The type B also has a way has differences. differences in the ovulation, the androgens, and then the cyst on the ovaries. So depending on the type that you diagnose, you can classify them as A, B, C, or D. Again, this is not very important, so we'll not spend much time here. So this is the ovary. This is the normal ovary. How it's supposed to look like. You you are supposed to see some very, very small eggs, let me call them the primordial follicles, the ones that are yet to develop. And then when the cycle is going on, about 20 of them begin to enlarge. Then with time, one of them will be selected as the primary follicle. It will grow bigger than the other ones. And then it will mature gradually. With time, it will break to release the egg. And then if fertilization doesn't occur, it will atrophy and then it will become the corpus albicans. So in PCOS, what happens is that as it is, let me change this. Okay. As it is said here, the ovary shows a lot of cysts measuring between 2 to 6 millimeters. And then some of them will be seen as like the corpus albicans, they become atretic. Okay. But you see a lot of the follicles, a lot of the cysts on the ovary. Okay. As you see here, you see many immature molecular follicles growing, and then these are the ones, the cysts, and some of them become like this one, atretic. But you see multiple of these cysts on the ovary. Like we saw in the beginning, it looks like this. Again, the cause of this disorder is unknown. What causes the excess androgens in the women with PCOS is not known, but there are some theories. Some evidence suggests that there's a genetic predisposition. If you have someone in your immediate family who has been diagnosed of PCOS, there's a higher chance that you are also going to develop it. It has also been noticed to be associated with people who have obesity and other causes of luteinizing hormone excess. But the PCOS can also cause obesity. So the obesity may not be the cause of the PCOS, but it's a risk factor. The exact cause of the condition is not known, but some people suspect that it is a family thing. Some people suspect that when you are obese, the chance that you are going to develop PCOS is also high. And if you have any tumor that is going to be causing excess secretion of the luteinizing hormone, the chance of you developing many cysts on your ovary and then developing the syndrome is also high. So some evidence also suggests that there are abnormalities in one enzyme. The enzyme is here, this enzyme. There are abnormalities in cytochrome P450C17. And then this enzyme is this cytochrome P450C17, it produces this enzyme, 17 hydroxylase. And then this 17 hydroxylase is the one that controls your androgen production. So when you have an abnormality in this cytochrome P450C17, and that enzyme causes you to produce abnormal 17 hydroxylase, you are going to end up producing excess of the androgen. And then that is what is going to cause the problem that come with PCOS. That is also a theory. It has not been proven, but that is what some people also believe. Some theories are also present that say that people with type 2 diabetes also at a higher risk of developing this PCOS. Again, the people with PCOS also usually tend to develop the type 2 diabetes. So we don't know if the PCOS is the cause of the diabetes or the diabetes is the risk factor. But that's also another theory. So let's talk about the ovarian cycle. When you are during the menstrual cycle, there are two phases, let me see, or there are two places that we look at. First of all, there's the HPO axis. So the hypothalamus will release some hormones that will affect the anterior pituitary to also release hormones. The hormones will work on the ovary, and then you'll be having your menses. So when you're looking at the menstrual cycle, we look at the ovaries and then we look at the uterus. The Yes, the endometrium, the uterus. So talking about the ovarian cycle, what happens when you're about to have your menses is that first of all, we divide it into two phases. There is the follicular phase of the ovarian cycle during your menses, and then there's the luteal phase. The follicular phase, basically, there is the phase that involves the development of the Graafian follicle, the follicle that is going to end up releasing the egg for fertilization. That is what the follicular phase involves. So as I was saying, about 20 of the follicles will be picked, they'll start growing, and then in the end, one of them will grow bigger than the rest to become the primary follicle. And then during the luteal phase, the primary follicle is going to break open and then release the egg. So that is the ovarian cycle. The phase is the follicular phase where the eggs are growing, and then the luteal phase where the egg will be released. Okay. The intervening period is the ovulation when the egg is released. So as I was saying, the follicular phase starts with the development of 20 to 50 follicles in the ovary under the stimulation of the follicle stimulating hormone, which is released from the anterior pituitary. So there's the gonadotropin releasing hormone, the GnRH. It comes from the hypothalamus, and that will go to the anterior pituitary to cause the uh, release of the follicle stimulating hormone. And then that will go to the eggs to cause the follicles to start growing. Okay, and then when they are growing, they produce estrogen. They produce estrogen into the bloodstream. There are three types of estrogen, but during your menses, the E2, estradiol is the one that is produced. The estradiol is produced during pregnancy, and then the estrogen is in menopause. So the estrogen that is produced by the follicles, the growing follicles, will cause the endometrium to proliferate, to thicken, ready for your menses. Okay. So as I was saying, around the 10th day of the follicular phase, where the 20 to 50 follicles are growing, the one of the follicles will become bigger than the others, and then it will grow to become the dominant follicle. Okay. The rest of the follicles will become arrested. Okay. Then they will remain where they are. In the next phase, some of them may another 20 to 50 will start growing. 1 second. So the ones that are no use, they will start to shrink, okay, and then they will not be used anymore. Uh, the cells, the granulosa cells of the dominant follicle, they release, as I was saying, estradiol, the E2 that happens during menses, and then they peak around the 12 day. So taking a cycle length of 28 days, that is the average one. Follicular stage begins at day 0. So around day 12, that is when your estrogen levels will be peaking. And then So these increasing estrogen levels will produce a feedback on the hypothalamus. And then the hypothalamus will also start increasing the amounts of luteinizing hormone. So around day 14 of the the cycle, the amounts of luteinizing hormone in your body will be at the maximum. And then this will cause the dominant follicle to break apart to release the egg called uh, the egg. Yes. So the process is called the ovulation, egg the oocyte. So if the egg is not fertilized, it degenerates within 1.5 days, and then the luteal phase begins. The luteal phase begins after the ovulation, after the egg comes out from the follicle. So this is just to let us know what happens in the ovarian cycle. This is, but in the pathophysiology, because of this cytochrome P450C17 causing abnormalities in the 17 hydroxylase, there is excess androgen production, the male sex hormones. And then the androgens affect this whole cycle that we described here, the ovarian cycle. So because of this, most of the follicles don't end up releasing the eggs. So these eggs, they remain in the follicles, and then the follicles start forming cysts. If the egg had come out, the follicle would have started to shrink, becoming the corpus albicans. But when the egg is unable to come out, the follicle becomes small fluid-filled sacs called the cyst on the ovary. So that's what happens. That is what goes wrong in PCOS. So when taking this syndrome of androgen excess, the eggs, irregular ovulation, and all of that, they will all lead to some signs and symptoms. Because the women have excess male sex hormones in their body, they, their menses will become irregular. And then the ovulation too, as I described, it doesn't always happen. So if you are able to test for your ovulation, you realize that they didn't ovulate, that their menses are heavy, they are long, they are unpredictable. Okay. And then sometimes they don't come at all. Because of the excess of the androgens, they develop acne on their face. They develop a condition called hirsutism, a sign where they develop hair in areas that are regular for men but not for women. Because of the male sex hormones, they develop like men. So some of them develop beards, chest hair. Uh, at the pelvic region, there is a pattern that the pubic hair is supposed to grow for men and women, but in women with PCOS and hirsutism, they develop the hair down there like men. Okay, so they have male pattern hair at their genitals, they develop facial hair, chest hair, and then some of them begin to grow bald like men. So they have hair growth like men because of the increased androgens. They become infertile because of the unpredictable, the periods being affected, the ovulation being affected. And then they have a condition called acanthosis nigricans, where there's darkened skin in the armpits, on the nape of the neck, and then on some skin folds. You see that in their armpits, it will be darker than most people because of the excess androgens. So there are tests that you're supposed to do to diagnose PCOS to help in your diagnosis. The first of all, you have to confirm that there are excess androgens. So there are several hormone tests. There are tests for testosterone, there are tests for estrogen, there are tests for the luteinizing hormone, follicle stimulating hormone. Just to make sure that it is true that there are excess androgens, and then to rule out other causes of excess androgens that are not PCOS. Okay. You are supposed to do your scan to identify the cyst on the ovaries. Okay. So an A pelvic ultrasound will be able to pick up the cyst. You can do MRI CTs to look at the ovaries, to look at the other organs as well. Because another cause of excess hormones is a tumor on the adrenal gland. So if you are able to do a scan of the adrenal gland as well, maybe you pick that and it will not be PCOS. Because the excess hormones in the body, they lead to obesity. Eventually, they will lead to this, their body becoming resistant to insulin. So most of them develop type 2 DM, as we mentioned earlier. So their blood glucose test you're supposed to do, the oral glucose tolerance test. You give them the sugar, and then you check how the body is able to manage the sugar after 1 hour, 2 hours to diagnose your diabetes. There's the HbA1c, the random blood sugars that we do. The PCOS causes is associated with metabolic syndrome, a syndrome where people have they have truncal obesity. So at the stomach, at the abdomen region, they have excess fat there. They have high blood pressure, they have hyperlipidemia, a lot of cholesterol, and then they have diabetes. So metabolic syndrome, the PCOS people, some of them develop metabolic syndrome. So you can do your chemistries to uh, look at how the kidneys are faring in the case of diabetes. Diabetes can cause nephropathy. So you can do your chemistry to look at your kidneys. You can do your lipid profile to look at the lipidemia that comes in some of the types of PCOS. You can look at the liver for any abnormalities there, because and it's the PCOS also can cause a non-alcoholic fatty liver disease, where there will be fat accumulation in the liver. So it is also good to examine the liver as well. Okay, so in making the diagnosis of polycystic ovarian syndrome, you first, as I said, have to make sure there is excess androgens in the system. Okay, so to establish, and then after you made the diagnosis, the excess androgen, you can do it with the test that we mentioned, the testosterone test, and you can also look for hirsutism, the male pattern of hair growth in the female. You can look for acne, and then the hormone measurements I mentioned. So to establish this diagnosis, the first one is you have to diagnose oligo-ovulation, and so this is reduced ovulation. So we are expecting the females to be ovulating every month averagely. But if they are not ovulating every month, but they are ovulating sometimes, that is oligo-ovulation. And then anovulation is total no ovulation at all. So this, you are ovulating less than you should. And this, you are not ovulating at all. And then this is usually marked by irregular menstrual cycles. Okay, sometimes it doesn't even come at all. There are no patterns to it. And then you have to diagnose your hyperandrogenism, and then you have to diagnose the polycystic ovaries. So these are the three criteria for diagnosing PCOS. Irregular menses, hinting at oligo-ovulation or anovulation. Hyperandrogenism, this hinted by your hirsutism, your acne, and then diagnosed with your serum measurements, and then seeing the polycystic ovaries on the ultrasonography. So if you get these three things, then you can make your diagnosis of PCOS. Again, it's important to rule out other causes of symptoms that look like PCOS, because there are some endocrine disorders that can also produce excess of the hormones, and then they can look like PCOS, but they will not be PCOS. So you have to rule those ones out, like Cushing disease, where there's excess cortisol production. Okay, the excess cortisol production will also mimic the PCOS. It will make them develop the metabolic syndrome, the hyperlipidemia, hypertension, truncal obesity, and the diabetes. Okay, so it could just be Cushing syndrome. It could be hyperprolactinemia. It could be an adrenal tumor causing your symptoms, not PCOS. If you have ruled them out and then you have these three things, you can diagnose your PCOS. So because of the excess hormones, there are some complications that come, especially in pregnancy. The people with PCOS, when they are obese and then they become pregnant, they end up developing diabetes sometimes. Because of the diabetes is a risk factor for preterm delivery. So before the child is fully developed, it's mature to come out, the child may come out. Okay. And then the diabetes, the high blood pressure, it can lead to an increased chance of developing preeclampsia, which is the high blood pressure in women who are pregnant. It's very bad. The metabolic syndrome, as I've been saying, it can be a complication of the PCOS. Because of the hyperlipidemia and the diabetes, they can end up developing coronary artery disease, narrowing of the blood vessels that supply blood to the heart. Because of the fat, the diabetes, they affect the lining of the blood vessels, and then at atherosclerosis. This is similar to the coronary artery disease. In the coronary artery disease, there's like narrowing. And then the atherosclerosis, this narrowing is due to fat plaque. Okay, so in diabetes, there will be excess deposition of fat globules under the blood vessels. And then with time, some macrophages will be involved, several processes. This, this deposition will start leading to a fat plaque, okay, and then it will start pushing into the inside of the blood vessel. It will be narrowing the blood vessel. Eventually, the plaque can break off to cause stroke, to cause heart attack. Okay, so that's atherosclerosis. I think I'll create a topic on that and we can talk about that. Because of the irregular menses, and then the excess hormones, they are at a chance of developing endometrial cancer as well. And then the non-alcoholic fatty liver disease, as I described, where there will be deposition of fat in the liver, but not because you drink alcohol. It's usually seen in alcoholics, but in some people with excess lipids, it can be deposited in the liver, then cause non-alcoholic fatty liver disease. There's a complication of PCOS as well. So there is no cure for PCOS. It's a chronic condition, but there are several treatments that can help. Eating a healthy diet and getting a lot of exercise will help reduce your weight and then the risk of developing type 2 diabetes. When you exercise, your muscles take up glucose from the bloodstream. So it helps to sensitize your cells to insulin, to
Are you done already? I just finished with my. Are you done, please?
No, he's not. I think it's a network problem.
Oh, let's see that he connects. I just finished with a session somewhere. Okay, he's back. Right. Where are the others? Stop. Please continue. Let me make you co-host again. Please go ahead. You are co-host now, Doc. You can share. You can unmute your microphone, and then if you are in a good position, we cannot hear you.
Oh, sorry.
Okay, great. That's okay.
So when you exercise, as I was saying, it helps sensitize your body to insulin, to the sugar uptake, and then your risk of developing type 2 diabetes is reduced. Having reduced weight will also help a lot because obesity is a risk factor for diabetes, hypertension. So when you have reduced weight, it will help in your management of PCOS. Having a reduced weight has also been shown to help in the fertility problems. Okay, so if you have PCOS and you are obese, reducing in weight will help you get pregnant if you want to. And so there are contraceptive pills that can help to normalize the menstrual cycle, the irregular, no pattern menstrual cycle, and then it will help with the symptoms as well. There are medicines that can help with the acne, their treatments. There are, yes, ones that can help with the hair growth as well, caused by the PCOS, the HER2. There are other treatments for infertility, such as in vitro fertilization. And then we put them on metformin when they are diabetic. It helps with their fertility issues as well. There are several other medications. Sometimes they are put on the progesterone. That also helps with their fertility issues. So yes, I didn't go into much details, but there are medications. There are medications for the acne, the unwanted hair growth, the infertility, the irregular menses, and then having your adequate exercise, your weight loss. They are all going to help in the management of your PCOS. So there are differentials. There are things you are supposed to rule out when you are dealing with PCOS. It could be just metabolic syndrome. It could be an adrenal tumor secreting the excess hormones. Some people are just hairy in their family, and then the pattern of their hairiness is like in the male pattern. So the person may not have PCOS. Maybe in their family they just have the condition that causes the male pattern of hair growth. And then it could be Cushing due to excess cortisol production from the adrenal gland, giving you the symptoms that look like PCOS. So that is a short discussion on PCOS, polycystic ovary syndrome. It is sometimes thought to be familial. If someone in your family has it, the chance they are going to develop it is increased. Some evidence is pointing to this enzyme, 17-hydroxylase, causing all our problems. Because it's the thing that causes the androgen production. So when there's a problem there, and you have excess androgen production, you are going to end up developing the polycystic ovary. Because the follicles in the ovaries are not going to release the eggs that they are supposed to do. And then the eggs in there will cause the follicles to become fluid-filled sacs or the cyst. So polycystic ovary, multiple fluid-filled sacs on your ovary with excess androgens and then irregular menses. That is basically PCOS. There's no treatment, but there are lifestyle management, there are medications to help your symptoms. So that is a short discussion on PCOS. If there are any questions, I will attempt to answer them with Dr. Eric and then. Okay. So there are no
Sharing
questions.
these important slides for us. It's a great lesson. I feel that this is about women, right? Yeah, but
Yes,
whatever
please.
it is, it still concerns a man because every man has a woman in his life. All right. We'll share the recording. Yes, go ahead. Jane wants to ask a question. Go ahead, please.
No, so I wanted to know, you said it's chronic, and if maybe your mother or grandparent is having it, there is higher chances. But we know maybe your mother is having it, right? Is there a way to
Yes.
prevent it from a child that is coming, or the kids from getting it too, or there is nothing you can do about it?
Yes. So the lifestyle modification is the best thing for the children right now. Again, we don't know the exact cause. These are theories that people have put out, but it has been studied that if you exercise well, you have your weight checked, okay, and then it is not, you are not obese. These things can help you, because as some people also suggested that type 2 diabetes is the thing that causes PCOS. And if that is the case, and you are eating foods that you're not supposed to eat, you are not exercising, you have sedentary lifestyle, okay, and then you develop this, you can end up developing the PCOS. So if the parent has it and then the child is at risk, one, the child should always be screened so that in case it is actually
Doctor,
happening, we can.
Dr. Brown,
Yes,
please, I was saying that suppose I'm a woman, right, that is
yes.
obese, having it. Is there a way that I can do so that even before I take in the seed, my kids will not get it? Or once I have it, definitely.
No, 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 there's nothing like that. I mean, that I have seen.
So once
There's
you
nothing
have it,
like that.
you are giving it to your kids.
There's a chance that you're going to give it to them. It is not guaranteed, but they
Probability.
have. Your line is breaking.
Please, can I be heard now?
Yes.
Okay, I was asking, what's the probability?
Oh, okay. That is a good question. I did not come across anything like that, but I will read on it and then I'll send it to the page.
Okay, thank you. And is it gotten from the male gene or the female gene? I'm asking based on the probability that maybe a woman is having a 50% chance of giving it, and maybe the husband is not having. Does that reduce it for the child? And that means when both parents are carrying it too, the child will definitely have it, right?
Okay, so that is also another good question. The men don't have ovaries, but they they probably have they have the enzyme 17 hydroxylase. So yes, a man may carry the problem and then send it to the child. But again, we have not diagnosed the cause of the PCOS in the first place. So first of all, these are just theories. These are just theories. They have not been proven. But in case it is that, and then yes, it is due to cytochrome P450C17. I'll research on it and then I'll see if the men also pass it down to the children as
well. Okay, thank you.
Okay, so in addition to that, we see that all these are assumptions that people are making. So it's really difficult for you to pinpoint that this is the actual cause of it. But the only thing that we can do is the lifestyle modification, such as, let's say, the obesity and those stuffs. You have to know how to go about it. But one thing that's mostly is a worrisome for us is the infertility in the women. So the best thing is, as you give birth to the child, during the adolescent stage, you have to be monitoring the beta ACG levels. Okay. Monitoring. Okay, sorry. So you have to be monitoring the beta ACG levels so that in case it's rising to the abnormal state, we can just stabilize it to prevent the cause of the infertility in the upgrowing woman or the lady that is coming. Okay. So that's one thing that maybe we can also work on. But aside that, all this there is really needed. And the other thing is the investigation. The main goal for it is the transvagina. Yeah, at times the pelvic USG will be giving you some false results. So as Dr. Frank said, you can do the MRI and those stuff, but those ones they are expensive than the transvagina. The transvagina is able to visualize the morphology of the ovaries. So that one you can just pinpoint that that's the real culture. Okay, so thank you.
Wow, thank you very much. Janet was going to go again, but let me see if I can ask a question briefly. When Dr. Eric spoke, he mentioned of monitoring, is it the ACT levels or something? Please call me on that, and how do we do that?
Oh, it's a laboratory investigation. So actually, that's when you are pregnant, it has a level that you're supposed to get. And then if you are not even pregnant, we have a limit that you're supposed to get. So talking about if you are recording a very low values concomitantly, meaning you have to be careful and then you have to seek ONG specialist so that we can correct that hormonal imbalance first to avoid any unnecessary infertility in future.
You said this in relation to adolescents, so that's where I got a bit curious. Okay, so I wanted to know, how do we apply this test to the adolescents and the teens?
Yeah, so as they get to the adolescent stage, you have to be monitoring because that's the chances where how should I put it? That's when you start ovulating and that's when you start menstruating. So as you are saying, it's a hormonal factor.
Okay.
And if you are not having the right hormonal balance, meaning it's going to affect the ovulation and then the menstruation as well, as the pathophysiology suggests. So if if the child is not able to menstruate, let's say a month or two, or if the child is getting irregular in menses, that's when you have to start monitoring the hormonal distance so that in case there is imbalance somewhere, we can give drugs to prevent it and then
Okay.
to balance the hormonal distance so that it will prevent those future infertility.
Oh, okay. Okay, I think I get it now. So one of the quick ways of observing is where you see irregular menses, even at adolescent stage. Wow, that's good information. Thank you. Thank you. I really appreciate. Jane, you wanted to say something else? I saw your mic.
I think he had answered it. I was about to ask that maybe a mother that is aware of their situation should probably, as the lady starts menstruating, start monitoring it so that it doesn't become hard for them to conceive or live a
Wow.
lifestyle so that they will not pass it to their kids.
Very good information. Thank you. Thank you so much. I love this. Dr. Frank, you wanted to conclude or say something else, then we end it.
Yes. So I quickly checked some studies.
Okay.
As Dr. Eric was saying, concerning okay, so let me start with the risk of developing it. Several studies have been conducted on the risk of you developing PCOS if your sister or your mother has it. And then some of them brought up 4%. Some brought up about 20 to 40% chance of you developing it if your mother or sister has it. So the numbers are all over the place, some as low as 4%, some as high as 20 to 40% chance of you developing it. But you are obviously at a higher risk of developing it if a relative of yours has it, as compared to someone who has no family history of it. And then concerning the cytochrome P450 C17, yes, it's an enzyme that is found in both men and males and females. So you may get it from your father if your mother passes the abnormal one to him. So you can also pass it to you. It doesn't mean only you are going to get it from your mother. It can also be from your father's side. It's an enzyme in the liver. So both males and females have it.
Anyway, thank you very much. Do we have any further something to share? Okay. Well, really want to thank you. Thank you so much for this initiative again. And I hope that our friends would really hold on a second.